of commitment that you can refer back to. And as long as you have your lead, whether that be a physician or stewardship lead, your medical director can go back to those admin and talk to them about what are the needs of the stewardship program. Also, it's important to make sure that stewardship-related duties are in job descriptions. So if you do have an ID or stewardship pharmacist, to have it in writing that part of their time is dedicated to stewardship. One of the struggles we had is that when I first started, that wasn't necessarily in my job description. So I did a lot of staffing as well as stewardship, so I wasn't truly a full FTE dedicated to stewardship. And obviously, hospitals have needs for operations and whatnot. So having that written in at least guarantees that the pharmacist can have some dedicated time to stewardship activities. And then ensuring staff from relevant departments are given sufficient time to contribute to stewardship activities. So that kind of ties back into the previous bullet point. But for those from older disciplines, such as the microbiology lab or infection prevention, or a hospitalist that's part of your multidisciplinary committee, it's important that they also have time to commit to attending the meetings and also helping ad hoc to your initiatives. So after laying the foundation, where do we begin? There's obviously a lot to tackle, and it really depends on the resources at your hospital. Some hospitals are very large, and obviously you can't rein in all the antibiotics at once. Some of the smaller hospitals, you might not have the resources on site. So some considerations here are, if you have no clinical pharmacist dedicated to stewardship, you can do the basics that any pharmacist can perform, such as antibiotic renal dose adjustments and IV to PO conversions. Those just require a protocol being put in place, P&T approval, and then the clinical pharmacist can take it from there. If your facility has access to timely and accurate microbiology results, and certainly not every single hospital has that, you can leverage that to make antibiograms, and those are really important for having facility-specific antibiotic recommendations for disease states, and also just having an antibiogram to refer to for empiric treatment. And then if you have a stewardship team with dedicated time to review patient cases, that's really one of the more ideal states. The stewardship pharmacist can do prior authorization of restricted drugs, such as those that are ID restricted, prospective audit and feedback, that is one of the bread and butter activities of stewardship pharmacists, e-labeling of antibiotic allergies. So as you know, a large portion of our patients who come into the inpatient setting have allergies listed, but a lot of these are not true allergies, and a pharmacist with an assessment tool can help delabel those spurious allergies. And then antibiotic duration review, so those extra long durations of therapy that we know occur in the hospital because someone forgot a stop date, is something that the stewardship pharmacist can review and act upon. So for the resource-limited setting, there's certainly some low-hanging fruit that can be implemented, usually right off the bat, as long as you have some pharmacists that are willing to put them in place. So IV to PO conversions, as I mentioned before, there are a number of antibiotics that are highly bioavailable orally that can be switched as long as the patient has functioning gut with enteral absorption. So azithromycin, clindamycin, ciprofloxacin, doxycycline, levofloxacin, linezolid, metronidazole, rifampin, and trimethylsulfamethoxazole are the antibiotics we have on our IV to PO conversion protocol. And we know that with the combination of EHR, which can kind of tell you which patients are on these IV drugs, the clinical pharmacist can then evaluate to see if they're right for IV to PO conversion. Antibiotic renal dose adjustments, like I mentioned before, that just requires, again, a protocol, and our pharmacists adjust based on creatinine clearance. Antibiotic dose rounding can also be something that's implemented. It can help, round to the nearest vial size and save some costs that way. And then our kinetics monitoring. So vancomycin dosing as well as aminoglycoside dosing is certainly most pharmacists in the inpatient setting are familiar with. And one of the key points with not just dosing the drug is also evaluating for appropriate indication, and that in itself is a stewarding. for our vancomycin protocol, for example, our first couple of pages is specifically about evaluating if vancomycin is even appropriate for the indication listed. And so before even getting into the PK weeds, we have our pharmacists see if it meets criteria, and if not, they'll contact the provider to ask if they can de-escalate right off of vancomycin instead of getting it started. So stewardship, as you've heard, is a team effort, and stewardship is something that I know that our clinical pharmacists on the floors and staffing in central pharmacy do all the time, even on order entry. All these low-hanging fruit like IV to PO, dose adjustments, and vancomycin aminoglycoside dosing is something that our clinical pharmacists can do. In the past, it might have fallen to the stewardship pharmacist, but that really isn't necessary. The staff pharmacists that are available to you are able to do these with protocols in place, and these can be further optimized with clinical decision support. So if you have an EHR that already has some clinical decision support, that can really help identify those patients faster so that the pharmacist can just go down the list and adjust renally, make IV to PO conversions as necessary. For example, we currently do have Idph, and we're able to create our patient lists with columns for IV to PO, de-escalations, renal dose adjustments, and that really helps speed up the ability to evaluate patients for necessary adjustments to their antibiotics. So when we were first building the stewardship program, we had to go with a stepwise approach because you can quickly become lost in all the initiatives you want to start in the beginning, since there are so many different avenues to take. So this is kind of the process that the CDC document also recommends. One of the priorities are first to form that Antimicrobial Stewardship Committee. So in the beginning, that might be a small group, the stewardship pharmacist, the medical director of stewardship, or a physician champion, and anyone else who is interested, whether that be other pharmacists, infection prevention, microbiology. But having a group started and having people to bounce ideas off is critical so that moving forward with initiatives, you have buy-in from multidisciplinary groups. If possible, hospital stakeholders as well are important to have in the committee. So starting with a single priority area for stewardship was how we tackled it. So focusing on one initiative instead of attempting to do too many changes at once is a good way to start in the beginning. And then ensuring appropriate policies or guidelines are in place. Certainly you can create a guideline from scratch, but there are certainly national guidelines, IDSA, CDC, et cetera, that have great references that you can cite and adapt for your facility. After that, it's important to educate your staff. So whether it's pharmacy, nursing, or your mid-levels or providers, there does need to be a public kind of campaign for your stewardship program, especially if it's new, so that people know who you are, what the program is about, and the importance, of course, of stewardship. In services for pharmacists, the pharmacy team, grand rounds maybe for the hospitalists, if you have residents or learners, those are a great opportunity to kind of introduce yourself. We've also utilized new hire competencies. So for pharmacy, we've had a stewardship module and kinetics module, and we've had more also coming for the NM system. And then lastly, to implement the stewardship activity once all that groundwork has been built up at the targeted priority. So that's a lot of high-level building of the stewardship program, but I wanted to kind of go over how we first approached it at Centegra Health System back in 2017. So we wanted to focus first on our antibiotic formulary. There was loosely some restrictions for certain antibiotics that were broader spectrum, but nothing really formal. So we revamped the antibiotic formulary and established a 3-tier system. So tier 1 were antibiotics that were not restricted, so any provider could order them. Tier 2 antibiotics were somewhat broad spectrum antibiotics that would require a stewardship pharmacist approval, and for the most part, we did this retrospectively. This included 6 antibiotics. Sorry, the print is really small there, but it's amsulbactam, aztreonam, cefepime, ciprofloxacin, ertapenem, and levofloxacin. And then tier 3 antibiotics were ID consult required. So these included meropenem, acyclovir, some of the broader spectrum antibiotics that would need a formal ID consult. So once we revamped the formulary, we ensured that an appropriate policy or guideline was in place. So we had a antimicrobial restriction policy put together, and this was approved at our stewardship committee meeting, as well as then at PNT, which went on to the med exec for final approval. So even though we had the document in place, obviously only really us, the stewardship group, were intimately familiar with it. So we did have to do some education and kind of a campaign for our stewardship formulary. So we did pharmacy and nursing education via in-services. So myself and my colleague hit up in-services for pharmacy at huddles as well as nursing. So catching them at 7 a.m. and 7 p.m. So that they got a sense of, what's changing with our antibiotics and what you might be seeing pop up with restricted ID antimicrobials. And then we posted some flyers for the medical staff, so in their physician lounges, to give a brief overview of what had changed. So some initial problems we encountered with having this restriction in place was that, again, our EHR Paragon had very limited clinical decision support features. So we were not even able to implement a hard stop for our ID restricted antimicrobials. So meropenem, anyone could still order it. There was no hard stop or pop-up. It was really up to the frontline pharmacist in the queue to realize, oh, this is not ID that's ordering it, and to follow up and see if they were planning an ID consult if ID wasn't already on there. We were also unable to do the same with our stewardship pharmacist approval required antibiotics. So kind of same problem. We really did that more on a retrospective basis when we were reviewing patients and saw them on Amsulbactam or Aztreonam. We were not even able to run reports, and there was no IT analyst or IT resources whatsoever for us at that time. So we were kind of stuck where we were, reviewing patient by patient. So as you can expect, this was very time intensive, and identifying patients was even taking a lot of our time. There are probably 10 to 15 patients on these tier 2 stewardship pharmacists required antibiotics per hospital, and that adds up to quickly 30 patients. And me not necessarily always being in the stewardship role, that left one pharmacist to review quite a lot of patients. And what we found out is when we did reach out to the providers, they didn't necessarily know who we were, that they weren't familiar with the new stewardship program that was in place. So our recommendation acceptance was low. They weren't that familiar with the restriction criteria and appropriate use criteria for these tier 2 antibiotics. Another problem was that we had limited collaboration with the ID physicians at the time. We had a private group that kind of came in and out and had a large consult load, and were not necessarily working with the stewardship program. So one way to view this initiative that we had started is through a project management lens. So this, if you're not aware, is the quality triangle. So it's a visual representation of scope, time, and cost constraints for a project. And as you can see here in the 3 corners, cost, time, and scope are all proportional to each other. Scope is directly proportional to both time and cost. So when scope increases, time and money must also increase in order to maintain the quality of a larger project. So we were kind of tackling a lot at once, revamping the whole antimicrobial formulary and expecting us to be able to tackle all these broad spectrum antibiotics. So what we had to do is kind of look at this triangle and see where we could adjust so that we could still maintain the quality of our project, but maybe in a smaller scope. So with the cost factor, again, having the EHR that we had, and no clinical decision support, it would be a very costly endeavor to try and get funding for clinical decision support program. And at that time, there was no interest or possibility of getting that, so we were not able to change that. As for time, like I mentioned, it was taking a lot of time to review all these restricted antimicrobials, and with even 2 stewardship pharmacists dedicated to it, it just, even when we were able to recommend changes, we weren't always getting the acceptance that we were hoping for. So we weren't able to change that at the time. So instead, we wanted to decrease scope to get maybe a more intimate view of where our specific problem broad spectrum antibiotics were and focus on that first. So instead of looking at all tier 2 antibiotics requiring stewardship approval, we looked at those 6 antibiotics and focused on one that was being prescribed most inappropriately and went from there. So by refocusing and reducing our scope, we did some background work. And again, everything was manually collected since we had no way of really running reports. We just on day-to-day basis collected information on all patients on tier 2 antibiotics and found that ertapenem was most commonly being inappropriately prescribed. And we did this through an MUE that we presented at PharmD as well as the stewardship committee. You can see in the table below ertapenem used by indication, and at that time we didn't have required indications on antibiotics either. That was not possible with the EHR, but what we found was that it was mostly being used by surgeons for surgical prophylaxis. So this wasn't even treatment. This was prophylaxis empirically for a lot of our intra-abdominal related procedures. There's also intra-abdominal indications, known or suspected ESBL, and then a smattering of other indications. But clearly, a lot of this was being inappropriately used. So we decided to change ertapenem, a broad spectrum carbapenem, to an ID-restricted tier 3 antimicrobial. So then we went back to our stepwise approach and narrowing our scope with just ertapenem, we took the action of restricting it. And then to ensure appropriate policies are in place, we then updated our antimicrobial restriction policy, which we received approval at PNT, and then did another round of education, but this time very specifically looking at ertapenem and appropriate indications for ertapenem. We conducted pharmacy and nursing education again. We sent an SBAR memo to the medical staff, so that was sent by our CMO and medical director of stewardship, and it included details with ertapenem alternatives for surgical prophylaxis, and then also in our pediatric population. And then we posted flyers in the physician lounge as well, just to have those viewable by physicians while they are there. We put this initiative in place in November 2018, and you can see here the results of our initiative. So again, we wish we had better, more facility-wide data, but we had to manually collect. So we did count ertapenem days of therapy per 1,000 patient days in ICUs in McHenry and Huntley hospitals. We were starting to try to generate reports from the EHR, but really were not successful in that. So we're able to show in the graph below, the red arrow indicates when we started the initiative, and then Huntley is in blue, and McHenry is in purple with the ertapenem days of therapy per 1,000 patient days. So we did see a sustained decrease in ertapenem at both hospitals, and in that way we were able to narrow our scope and successfully show that if we tackle one item at a time, we're more likely to succeed than kind of biting off more than we can chew. So kind of reiterating what I already talked about, the stepwise approach is probably the best way to build your stewardship program from once a priority initiative is established and in maintenance phase, you can always go back to the stepwise approach and find another focus or expand your focus and rinse and repeat. It's recommended to regularly review and revise your approach as issues arise, since you'll always have challenges even in the maintenance phase and have to go back and possibly revisit some changes that need to be put in place. So determining a target, implementing, and maintenance is kind of the way that we focused our first few initiatives when starting. From there, we were able to become part of NM. We had our EHR changed from Paragon to Epic, which provided lots of clinical decision support that we desperately needed. And from there, we've really grown as a stewardship program. If you're interested in hearing more about what we've done as a system now from NM stewardship program, Aaron Westlander in the next session at 2:30 will talk about a lot of those items. But for the focus of this presentation, I talk more about pre-NM some of our challenges and approaches to stewardship. So in summary, resource-limited community hospitals face a variety of challenges in establishing a robust stewardship program. We found success by using a stepwise approach and choosing just 2 to 3 activities targeted at a priority area. Execution well is preferable to implementing more activities poorly. We found that the hard way, and consider the complexity in available resources to set realistic goals. There is no one-size-fits-all approach to optimize antibiotic use, so you'll have to find your own way when starting your stewardship program. That is the end of my presentation. Thank you all for your attention, and I'm happy to take any questions. Thank you. Hi there. Yes.
Hospital leadership on work.
Yeah, that's a great question. So if everyone could hear, just the question was about how to justify IT support from hospital admin. So when we first started the program, we were very fortunate that our stewardship lead was an ID physician and the CMO. So he kind of understood that data is critical to having to knowing where a stewardship program should start. And basically, when we had data to show the group, that's how we were able to justify further need of clinical decision support systems. So when we first presented the ertapenem data, obviously we were very limited. We were manually counting days of therapy per 1,000 patient days, but did show a difference. When we brought this back to the group, we were able to actually later on get Century 7 for our clinical decision support. And that was able to collect a lot more data more thoroughly as well for us. Thank you. Hi there. Mm-hmm. Yeah, so, for those who didn't hear, the question was, if I understand correctly, how do you tackle primary providers ordering ID restricted antimicrobials or broad spectrum antimicrobials and not wanting to consult ID necessarily? So that is a great question, and that's something we still struggle with, because even if we have pop-ups, I mean, they can still order meropenem, and it's up to really pharmacy who sees it in the queue to follow up and see if ID actually gets consulted or not. I think one of the ways we approached it was that first we wanted to establish a better rapport with our ID physicians, all of them. We now work hand in hand with our ID physicians. They are our stewardship champions as well. So if you have that line of communication, it makes it much easier, because then you can just contact them like, hey, this patient's been on meropenem for 2 days and it doesn't look like they have an ESBL or resistance. So that is the easiest way. But if you don't have that rapport, if you have privates that are, not even on site, I think it's something you should bring up to your medical director if you see a repeated pattern. And that's where data is very helpful. If you see those patterns and you can bring that to your medical director, it can be addressed kind of on a physician to physician level. Thanks for the question. Hi there, question?
Yes, you mentioned the assessment tool for the labeling allergies and eyes. Do those mainly resource or reference from the CDC website or their own?
Yeah, so the question is, where can I find delabeling of antibiotic allergy resources? So yes, CDC definitely has some great allergy delabeling resources, but I always like to plug NM. We have a fantastic stewardship and diagnostic program website that has a whole section just dedicated to antibiotic allergies. So I don't know if I can pull it up here, but adsp.nm.org, and under allergies, we have a protocol for or clinical pathway really to determine high risk, low risk, medium risk allergies, how to delabel them, whether that's through a graded challenge, or if you take a thorough allergy assessment, maybe delabeling it altogether because the patient had an allergy as a kid and it was just they vomited and that's not a true allergy. So yeah, happy to share those with you after the presentation too. Thanks. Any other questions?
Yeah, but, you look at your time with them, what would you your biggest what would you
Right, that's a hard one. So the question was, what was my biggest challenge and disappointment while with Legacy Integra as far as stewardship goes, and then biggest success. So I think one of our biggest challenges was getting ID buy-in. Obviously, our CMO and ID physician was ID trained, but he was no longer practicing on. He was not going on ID rounds anymore, so he could help from an admin perspective. But our ID physicians were privates, and they weren't really in alignment with our stewardship program. So it was challenging because they didn't really want to work with us most of the time with even simple de-escalation. So a lot of times we had to go back to our medical director to kind of figure out what kind of conversations the physician to physician could be done so that we could get our ID physicians to at least model the stewardship that we wanted everyone to be following. And then as for our greatest success, I think that with kind of the Erdapenem initiative, we then were able to jump on a AHRQ program that was for acute care hospitals back in 2019. And that was a great way to compare ourselves to the rest of the nation. So this program provided us with live webinars. It had us submit data, and we just submitted our ICU antimicrobial days of therapy data, and then got data in return from the rest of the nation from hospitals that were also in part of the program. And I think that really helped us get a sense of where we were, even though we weren't able to get extensive data on our antimicrobial use, and kind of jump-started where we want to go from there. Thanks, Mike. Any other questions? All right, well, thank you so much for attending. And if you have any other questions, feel free to talk to me after this presentation. Hope you have a great rest of your afternoon.